Hey, good morning, everybody. My name is Julian Marsden. It's my pleasure to be facilitating the UBC Department of Emergency Medicine Provincial Grand Rounds for January 13th, 2021. It's the first day of the NHL season for the Canucks, and the first time in history the impeachment proceedings have occurred twice for a U.S. president. So it's an exciting day ahead. So in addition to this talk, these rounds are coming from the ancestral, traditional, and unceded territories of the Squamish, Musqueam, and Tsleil-Waututh nations, which are only 3 of the 198 First Nations that reside within BC. So wherever you are receiving this from, please acknowledge that. A couple of notes. The second note I want to make is that on January 1st, Dr. Jim Christensen stepped down after 10 years of serving us as head of the Department of Emergency Medicine. We owe him a huge debt of gratitude, and I just want to take a time to acknowledge him for all of his amazing and impressive work that he's done over the last 11 years for the department, both emergency medicine, but beyond the department as well as in UBC. And words cannot really do justice to the debt we owe him, but thank you, Jim, for all of your work. And despite the fact that his Twitter account is no longer active, we hope that this is not the last we hear from Dr. Christensen. I'm also pleased to say that we'll be still in good hands, as Drs. Roy Purcell and John Talon have assumed the roles of co-heads, and we want to thank them for their commitment and wish them the best in this work ahead. And for today's presentation, we will try to mute you as you enter the session, but please, if you notice that you are not muted, please mute yourself so we don't have any interference and people can hear the speakers well. And any questions, please put them in the chat box, and I will be scanning that for questions for the speakers. So we have 2 speakers. I'm very pleased to introduce Dr. Bruce Forster and Mr. Colin O'Neill. Mr. O'Neill is a leader with the Health System Improvement Team of the BC Patient Safety and Quality Council, and he joined that council last November. And prior to this, he was the Chief Technical Officer and founder of a medical device startup company that invents and develops products for surgery and radiotherapy. And more recently, he's been an active patient partner helping to start the province-wide primary care patient voices group. He has 2 degrees, integrated engineering and honors in economics from UBC. So thank you very much, Colin, for joining us today and presenting with Dr. Forster. Second speaker is Dr. Bruce Forster. Bruce is professor and head of the UBC Department of Radiology. He was recently the regional head and medical director of diagnostic imaging, Vancouver Coastal Health and Providence Healthcare. He has been involved in clinical education and research aspects of sports imaging for 25 years and is associate editor to the British Journal of Sports Medicine and deputy editor of the Journal of Canadian Association of Radiologists. Dr. Forster has delivered over 400 invited lectures, many internationally, and has served as visiting professor in Canada, US, Indonesia, Singapore, Japan, Russia, and the Middle East. He is the author of over 140 peer-reviewed scientific publications and 130 educational exhibits, and served on the board of directors of the Canadian Association of Radiologists, and is currently the president of the Canadian Radiological Foundation. Dr. Forster was the lead physician for Choosing Wisely Medical Imaging, one of the most comprehensive appropriateness initiatives in the province, and is currently a medical lead for Essential Imaging Program with the BC Patient Safety and Quality Council. And in 2019, he was awarded the gold medal of the Canadian Association of Radiologists and was runner-up for the BC Patient Safety and Quality Council Doug Cochran Leadership in Quality Award. So thank you, Bruce. This is really a true honor to have somebody of your experience and obviously esteem talking to us today. So thank you, Bruce, and to Colin for doing this. I'm now going to hand it over to both of you for today's Provincial Grand Rounds, the title of which is Choosing Wisely for Medical Imaging in BC Emergency Departments, a Wise Choice. Gentlemen, I yield the floor.
Thank you very much, Julian. We really appreciate the invitation. As I was saying earlier, you know, these cross-specialty discussions are always, I find, very, very fruitful. I learn a lot. So looking forward to today's session. I do want to thank Sarah Carriere as well. For those of you who joined a little bit late, we were talking to her earlier. She is part of this team for sure, and she's the Director of Health Systems Improvement at the BC Patient Safety Quality Council. So let's get into it. I'm going to share my screen now here. So as mentioned, here's our title for today. And as background, I'm a fellowship-trained MSK radiologist, but I do a lot of work in Emerge, and I recognize many of the names and faces on this call today. I work at BGH in the Emerge at all hours, helping to provide the 24/7 care, and really enjoy the relationship I have with the Emerge department there. And kudos also to Jim Christensen, a close friend and colleague of mine who's helped me a lot over the years, including providing some advice about this talk. So deeply respect his impact here in BC. So just first our disclosures for us both. What we're going to do today is divide, it's not in half, but we're going to do two parts to the talk. I'm first going to review the medical imaging appropriateness projects that have been done in BC, emphasizing those in the ED, and look more in detail at the challenges of executing these initiatives. Because, we all know, I don't need to tell you, the ED it's a very busy place. And to introduce new programs, you better be respectful of workflow. You also better be respectful of patients as drivers for medical imaging exams in all of medicine, and be prepared to evaluate unintended consequences of such appropriate initiatives and look at their solutions. And then Colin's going to talk about the provincial program we're just launching called Essential Imaging, which Sarah's done a lot of work on, and its potential to reduce low-value medical imaging exams and the associated downstream testing to hopefully reduce ED congestion, a big problem as we all know. But the idea of essential imaging, as Colin will tell us, is to provide general instruction in QA/QI principles and to support these projects with hands-on assistance throughout the communities of BC. So that's what we hope to do today. So let's start off with some general comments about keys to success and quality improvement. Certainly understanding the system in which we function is really important, and it's a very complicated system. We all know that. So that's why, I'm not here to tell you how to practice emergency medicine, okay? There's nothing worse than some radiologist saying, well, here's the rules, this is what you got to do. That's not it at all, okay? That's why, we really adopt a team-based approach to this. And as you'll see, all the initiatives we've done so far and hope to do in the future involve a team of people with different interests and skills, including patients, by the way, which can hopefully, help in advancing these important programs in this difficult environment. I think it's really important to respect biology and clinical nuancing. As a radiologist, if I get a call from any of you or any other, referring doc, and the first thing that doc says is, I'm worried about this patient, that changes everything, right? And all of a sudden, things like guidelines and things fall away. So, we all know that if you're in the ED and, you're looking at somebody with query PE and has chest pain, and you've done your appropriateness criteria, and maybe they don't quite meet the metric, but you're worried about them, of course, you do a CT for PE. Of course you do. So I don't want to sound too prescriptive. I don't want to sound like I'm telling you how to practice your specialty. This is a team-based approach to this difficult problem. And, it goes beyond, of course, just the images, and that's why it's so important for us to have a discussion together. I mean, things that you have to deal with that the radiologist doesn't, like patients being outside Vancouver, physical disabilities, language barriers, the pandemic, for example. All these things have big impacts on workflow and workup, and so need to be respected. And, doing something like clinical decision support and hoping to derive benefit for patient care isn't just installation of software. That's the minor technical component above the ocean line. By far, the biggest thing is a change in culture, looking at patient care differently in a fashion that is decision-making that is shared with the patient, and looking at all the things in the system that, having champions, for example, that can move forward initiatives. All these things are culturally based, and they have a huge impact on whether or not projects such as what we'll describe and what we hope to do will be successful. So here's some of the principles we used in choosing wisely medical imaging, which was a program that went on for about 6 or 7 years. We started with a small project, and we wanted to make sure everyone understood it was patient-centered, about patient-centered care and optimal use. We thought, having data is really important, and making decisions based on that data is critical. Every study we did, every initiative we did, had a committee, a steering committee consisting of specialists, including radiologists, emerg docs, family docs. We had admin people on the committees, and importantly, we had patients on the committees. And then if we were successful, we would then try to deploy the project in other jurisdictions, and I'll show you an example of that in a minute. So, again, emergency physicians are at the coalface. I mean, all physicians who are referring doctors are at the coalface. Family docs are too. Radiologists, unless we're interventionalists and doing ultrasounds ourselves, are not so much. So we need to respect that. The evidence we use to guide ordering must be scientific. We have to respect your workflow. I remember asking a GP out in the Valley, who I greatly respect, how long did she think she had to explain to a patient why a CT for low back pain wouldn't be a good idea? And she said between 30 and 60 seconds. Okay, so, and she wasn't being, trying to be funny or facetious. That's the reality of it. So we need to respect your workflow in the ED and make sure whatever, patient education scenarios or, for example, decision support tools, that they are easy to use and don't take up too much time. And again, we look at this as an opportunity to enhance shared decision-making between patients, physicians, and their families, which is, I think, the way modern medicine is headed. Now, in terms of the evidence, this is from your own Canadian Association of Emergency Physicians Choosing Wisely webpage, and this is the first on the list, and it's shared in the radiology list from Choosing Wisely as well. Don't order head CTs in adults and children who've suffered minor head injuries unless positive validated head injury clinical tool. So, the sources, again, how good is this data? Well, generally speaking, this example, it's a citation from the Lancet and the Canadian Medical Association Journal, pretty good journals. Is the data on these sorts of advisories perfect? No, but it is solid. And I think that's one of the good things about the guidelines that are presently being shared, is that there is good but not perfect evidence. Now, the patient education resources, I said, are critical. So fortunately, Consumer Reports, as I think many of you know, have partnered with Choosing Wisely and provided patient information sheets, which can be either soft copy or hard copy, and help patients understand, why you are being sent home from the ED without a CT for your excruciating low back pain. And these kinds of things can save a lot of time and help patients understand much better what's going on. I'll share a little bit of that again in our project at St. Paul's in a minute. Okay, so what have we learned after 7 years of this appropriateness research in our region, in our regional department? And I think it's important that this research be done in Canada, as this cartoon would say. You seem familiar yet somehow strange. Are you by any chance Canadian? Doing the work in the U.S. is just a different environment. So I think we need to do the work here in BC, preferably, to be able to apply it most effectively, understand it. So we all know what Choosing Wisely is. Okay, it started by the American, the Internal Medicine Board, American Board of Internal Medicine Foundation in 2012, and it aims to promote conversations between physicians and patients and help to choose care that's, as you can see from this list, truly necessary, free from harm, etc. It's been widely adopted. I mean, it has been a success. It's a brand now, really is what it is. Lots of people have jumped on board. It's also controversial. There's no question about that. There is some controversy about Choosing Wisely. But generally speaking, it's been an important move forward in shared decision-making in North America and beyond. So the whole idea of Choosing Wisely, as you all know, is that each of these specialty organizations puts together lists of 5 things that physicians and patients should question before undertaking. On your left, you see the Canadian Radiology Association list. On the right, the American equivalent. And you can see that right off the bat, there are some similarities with respect to uncomplicated headache, for example. So, you know, in Canada, we're talking about don't imaging low back pain unless red flags are present. The minor head trauma one is in there, uncomplicated headaches, CT for evaluation of a suspected appendicitis in children, also in the American one, and then the Ottawa ankle rolls one at the end. So they are a little different between the US and Canada, but imaging shows up on a lot of these lists, like almost all of them. Here is the Canadian Association of Emergency Physicians list. You've all seen this. There's actually 10 instead of 5, and it starts off right off the bat with don't order head CT in adults and children who suffered minor head injuries. So suffice to say, there's a lot of imaging in these lists across the board, and there's a lot of overlap as well. And when you look further at the CAEP list, you see that MI-related guidelines figure in 6 of 10 of the rules. And you can see them here. Again, we have minor head trauma, we have low back pain, don't order imaging in patients with non-traumatic low back pain, don't order neck radiographs, patients who have a negative examination using Canadian C-SPAN rules, etc. Okay, with PE also being one in there, second at the bottom, of course. So I know you're all familiar with these, and just again to reiterate how much imaging shows up on these lists. So I think it's very appropriate that radiologists be involved in these committees and these initiatives to try to, make sure the right patient's getting the right test at the right time. Okay, but otherwise, why should we care? Why is medical imaging on all these lists, and why should we care if it is? Well, the Canadian Agency for Drugs and Technology in Health estimates there's about 5.6 million CTs and 1.9 million MRIs performed in Canada annually, with the annual operating costs estimated by CIHI to be about $3 billion. This is a huge cost to society. And although choosing wisely is not about reducing costs, it's about delivering better care, that is still a fact. It's very expensive. And of course, access is an issue. So the more inappropriate exams that happen, you delay appropriate ones. Appropriate imaging can also save time and also cost because it avoids unnecessary additional investigations, right? So if you find something in a vertebral body that ends up being nothing and you do a whole bunch of tests, including a bone scan, you've exposed the patient to radiation, you've also done additional investigations which weren't needed. And some of these investigations go on to invasive biopsy, etc., and that can also result in complications. We'll see later that imaging minor head trauma in the ED can increase the average length of stay, so and worsen ER congestion, which I know you all have to deal with on a regular basis. You want to reduce the risk of radiation to patients, especially in children and young adults. And again, you want to reduce the potentially invasive workup of incidental findings. Now, there's some data from 2007 that says that 1/3 of all physicians acquiesce to patient requests for tests or procedures, even when they know they're not necessary. I don't know that that's still the case. That's 13, 14 years ago now. And then there's also an interesting quote from the paper about the same time saying physician decisions account for 80% of all healthcare expenditures. I don't know what they qualify as a physician decision, but that's an interesting piece of data. Suffice to say that we all know that physicians make decisions that do have an impact across the board in health, including outcomes and costs. Now, clinical decision support in the ED has been studied a lot, and you know more about this than I do, but I just highlighted 4 papers here. And one on non-traumatic headaches, find that clinical decision support at point of care reduced the rate of CT from 15.3 to 9.5%. And then using the Wells criteria for PE, one study showed a decrease of PE studies, statistically significant decrease, an increase in yield using the Wells criteria. And when physicians overrode the clinical decision support system, the yield was 51% lower. And final example, clinical decision support decreased pediatric CT and minor head trauma from 24% to 21.6% with no change in positive findings. All of these from the emergency and radiology literature. So certainly there's lots of experience with CDS in the ED. And so we wanted to look at our own experience here in Vancouver. we chose St. Paul's Hospital ER as the place to do our first project. You'll recognize on this list David Ugulnik, who I see is on our call as one of our authors. He was so helpful in getting our red flags into your automated order entry. You'll also see family physicians, Nardi Estrada may recommend, Damon Ramsey, and then some radiologists and some administrators. So this is our typical team, and of interest is the first author is a medical student doing a flex project. So this is what I'm going to talk about for the next 5 minutes, this project, which we published in 2017. So essentially what we wanted to do is take some low-hanging fruit, which is low back pain because it's so common and in the literature often said to be over-investigated. So what we did was, with David's help, we put the red flags into your into the physician order entry, okay? And you had to check which one of the red flags the patient had. But if you didn't check a red flag, you had the ability to enter free text in this box, okay, where the red circle is. This is called a medium stop. That is, if you didn't have a red flag, you could still get the exam done. We think that's important. A full stop would be if you couldn't get the exam unless it was a red flag, unless you called the radiologist. We think that is not respectful of workflow. Of course, we were able to analyze what people wrote in that box, and that was helpful in understanding ways in which we may have fallen short in our red flags. So this looks a lot like some of the literature in your own BC Emergency Medicine Network, which I know Julian and Jim have had a lot involvement in, low back pain, of course, figures there, and the red flags are prominently displayed. So here's what we do in these projects. We start with a pre-intervention analysis of physician ordering for low back pain. We then produce an intervention. In this case, you've seen it. It's red flags inserted into the automated physician order entry, which is a CDS, a clinical decision support tool. And then we analyze its impact. Okay, and we basically in this study had 3 metrics. First metric was low back pain visits as proportion of all ED visits. And I can tell you that did not change pre and post intervention. It's important to make sure that there wasn't a sudden spike in discitis, for example, at St. Paul's Hospital. That would change the data considerably, but that did not happen. Metric 2 was low back pain visits with medical imaging order as a proportion of all visits. And 3, you can see physician variation in ordering such tests. So here's our results for metric 2. And what we see is after the intervention, we did pre-intervention data accumulation in 2014, post in 2015. We can see that we found a reduction in the percent of patients that had an imaging exam for low back pain, 21% pre-intervention, 16% post-intervention, statistically significant. Now you notice that we did have the lowest value in more than 2 years in May of 2015 at 14%. But then we had a spike right after that in July, around the time that the possibly new residents joined the service. Now we have no way to prove that was the cause of why it went up suddenly in July. It's one hypothesis. But we did see a statistically significant decrease in number of exams ordered. If we look at the physician variation, we see, again, this difference, 20% of orders pre-intervention, 15% of orders after intervention. And if we look at the top 25 physicians at St. Paul's Hospital, who are responsible for 76% of the exams, we find that 16 and 25 reduced their orders to a mean of 15%. So it did seem to reduce variation somewhat, and the standard deviation bars are also tighter, indicating that indeed when you look at the individual anonymized data, there are always outliers in any data set. And if you can help the outliers, then you help the system. So reducing variation is good, but it also, you have to be careful how you handle that particular data point. If we then look at all low back patients across BCH, there's in 2014 there were 6,420 low back pain visits to the ER in Vancouver Coastal PHC, and if we can avoid 5% of those exams, then we save 321 exams, which of course, if you then extrapolate across the province, it's probably about 1,000 exams, and that's only for one indication. Okay, so you can see that there's a lot of potential to reduce unnecessary exams in this province. So what we then did is we took this information and we applied it to the lower mainland. And now, this is not something that emerge docs have to usually deal with, but all outpatient exams go through central intake. And what that is basically the same kind of red flags that are up there for low back pain, and the physician needs to check off which red flag pertains to their patient, and then the exam is then booked. Now, unintended consequences are really important. So we looked at two in particular. First question is, okay, fine. You don't image a patient with low back pain at St. Paul's ED, but then, a week later they come back as an outpatient and get the same exam they would have had anyway. How is that helping? We looked at that and we found the percent of low back pain visits without medical imaging who returned as outpatients was the same pre and post intervention. So patients did not come back, okay, over the course of 6 months to St. Paul's Hospital or anywhere in Vancouver Coastal Health for repeat imaging examination, any more so than before the intervention. This we attribute to patient education. In our project, every patient received a paper-based explanation of the project and why they didn't need imaging, okay? We also sent the same to their primary care physician, so everybody was on the same page with respect to the project. Second, unintended consequence is really important for all of us, and that's what's the likelihood of missing a significant diagnosis in patients who do not get medical imaging for low back pain. And our analysis showed that, in fact, the proportion of patients for low back pain who were discharged from St. Paul's Hospital, ED, without medical imaging and visit another department within 30 days is not statistically different before and after intervention, okay? So patients were not coming back with undiagnosed severe disease over this short interval, okay? Those that did come back, the vast majority had, again, sciatica or acute low back pain as the same diagnosis, nothing more sinister. Now, again, I admit this is short-term data, but this is an important consideration, and projects should include this metric, I think, to help physicians gain confidence. I'm going to spend just a bit of time on some other projects. That was the lengthiest one. Another project we did was minor head trauma at Richmond Hospital, using the typical criteria as defined by the Canadian CT head rule. Patients who have a witnessed head injury within the past 24 hours, whose GCS is greater than 13, have a near normal level of alertness. And so we did a pre-intervention analysis on this group of patients in 2015. And in this case, we didn't need to do much of an intervention. And this is one of these things about these projects. Sometimes things go in a different direction. So what we found is, again, here are the population of interest to it, our target population. And we had 5 metrics, and here they are here. So first, at Richmond Hospital, there were 52,000 visits to the ED in 2014. 1.1% of patients had minor head trauma. 29.3% of those patients had a head CT, and by far the majority of those were non-contrast head CTs. So this is pre-intervention data. And this was a difficult project because at the time, the way ordering was done in the ED is with paper requisition. So we weren't able to use automated order entry. So we had to do a chart review, which was not great. But what we saw is that 65 out of 84 charts reviews 100% appropriateness for the Canadian CT head rules, which is fantastic. And there were some cases that were outliers that were not minor head trauma. Third T didn't have enough information to make a call. So basically, the steering committee recommended, there's not really much intervention needed here. Why don't we develop a patient education script for ED physicians, share the results, of course, so everyone knows how they're doing, and make sure that we collect ongoing data. So an example of sometimes you don't need an intervention if you find that the pre-intervention data is satisfactory. One interesting unintended consequence, or maybe not surprising consequence, we measured the median ED visit, average length of stay, for patients without head CT was 1.8 hours. For patients with head CT at Richmond Hospital was 3.7 hours, a difference of 1.9 hours. Now, you could say that those with head CT who are getting an appropriate imaging, maybe the selection bias, they're more seriously ill and need to stay in the hospital longer. That's possible, but I think it's pretty clear that although a head CT takes literally a minute, it takes far longer than that to get the patient through the queue, get the results to the ED physician, have time to re-see the patient. So this is, again, a potential way to reduce ER congestion in patients who who don't need the examination. And we all know that the wait in ER, and anywhere for that matter, can be very stressful. Finally, headaches and neuroimaging. So the yield for imaging in headaches, we all know is very low. We learned this, in medical school, it's about 0.4% for clinically significant abnormalities. And only 8% of patients with brain tumors indicate headaches as their first symptom. And we know that, migraine sufferers it's a terrible disease. It's got a very difficult examination to be sure of that that's what the patient has. So, with that caveat, here are the facts about headaches and neuroimaging. And the cost is huge. About $5 billion per year is spent on imaging for headaches in the U.S. We all know what those red flags are for headaches, thunderclap headache, additional symptoms like fever, neurologic deficit. And so what we did was we did Project Lionsgate Hospital. Again, we're trying to have a regional approach and move the projects around. Everybody can share the joy of these projects, if you like. And this was an outpatient study, so it doesn't as much pertain to ED. And as an outpatient study, it was also hampered by the fact it was paper requisitions again. So what we had to do is attach the red flags for headaches to the requisition as our intervention. Okay, and although that was awkward, we were able to show a significant decrease in the monthly average of head CTs after the intervention at Lionsgate Hospital, dropping from 120 to 94, which is a 22% decrease and statistically significant. We also again studied whether the patients were going to other sites, and we found they were not. You'll notice also there's a lot less variation from month to month after the intervention. Again, we were pleased with those results. So let's circle back to the question that we asked at the beginning of the presentation. Is choosing wisely medical imaging, ED, a wise choice? What I hope I've been able to show is that research in our province has shown a modest decrease in target exams without significant short-term negative impact on care. And that is an important point. We'd love to follow these patients for 5 years, but those studies are very difficult to do. And like many things we do in medicine, we act on evidence that may not be perfect. The workflow for the ED, like in any physician environment, has to be simple, seamless, and quick. That has to be delivered. Point of care is most effective. I mean, I've done lots of talks for all sorts of physician groups on low value imaging, and everyone, listens and says, okay, that's very interesting. And then the key is, do they go back and practice the same way? And it's human behavior that they often do. Point of care is much more effective. It's really important to have champions on teams, and all members of the department and community need to be on side. And this is important down the referral pathway from nurse practitioners, family and DE specialists, so that everyone is following roughly the same guidelines and not doing exams that are appropriate when others have made the choice not to. We've talked about patients with drivers for medical imaging exams. So true. I know we all feel it as physicians. We need to provide patients with educational material so we can arrive at good decisions in a shared fashion. And finally, again, I just want to reiterate, it's very important to respect clinical judgment, okay? The rules are broken. They're not the rules, they're guidelines. They're not policies. So there's lots of exceptions. And data analytics are really important, but we have to handle with care things like reducing practice variation, because on some days things are just not the same as others, and we need to respect that. So the whole idea is to try and undergo a culture change so that when this province, hopefully one day, gets enterprise-wide clinical decision support, patients and doctors will be ready to get the best possible results from that important change. So that's my part of the presentation. I'm going to now turn it over to Colin to answer the question, if you're interested, how can I get involved? So I'll stop my screen share here, Colin.
Thank you, Bruce.
Pleasure.
All right. Hi, my name's Colin. I'm here with my colleague Sarah, and we're with the Health System Improvement Team at the BC Patient Safety and Quality Health. Our Essential Imaging Initiative is really here to support you and medical imaging during these challenging times. So COVID-19 has compounded challenges with medical imaging and emergency medicine. There may be increased patient anxiety, creating more uncertainty. And overall, there is a huge backlog of medical imaging. So our goal is to accelerate the spread of the new appropriateness guidelines and improve access to helpful tools and change ideas. So together, you know the ways to improve, and we can provide support and coaching to test those ideas, implement and sustain change, and help spread best practices. So there are numerous stakeholders involved, and collective competence is easier with effective communication between each one. The emergency physician, the radiologist, the technician, the patient, the nurses, and the administrators. All the stakeholders can work from shared values based on quality healthcare principles. So the key drivers behind our support are knowledge exchange between the stakeholders, relationship building to facilitate easier communication and shared decision-making, capacity building so you can sustain improvement into the future, as well as system support, providing a platform that saves time, sharing the council's resources and experience with improvement, and promoting that patient awareness. So our support is through an action series, which includes 5 one-hour webinars spread over a few months, with coaching support and a forum for the sharing of learnings, and the action series will start in March. Teams need to enroll by February 1st and will participate in the 5 webinars and coaching sessions, the Patient Voices Network, and other patient partner groups like BCH's Community Engagement and Advisory Network can be utilized for patient engagement. And a link to register is now in the chat. Resources are available for you right now that you can use on our website. These can help with awareness as well as patient engagement and communication. So some final words. As Bruce said, evidence does show that low-value medical imaging reduces the quality of patient care in all settings. New appropriateness measures with clinical nuance have successfully been implemented in pilot Lower Mainland EDs. And it takes a team locally to tackle these challenges. And now more than ever, low-value medical imaging needs to be reduced. This Essential Imaging Action Series provides a framework and access to resources to facilitate effective communication and collaboration. So please feel free to reach out to us through our website or directly with our emails. And now please post any questions you have to the chat box. Thank you very much for your time.
And thank you, Colin. And Julian, I'll just add that Sarah has put a link into the chat box as to how to get a hold of us. Sarah, could you just provide the audience with an update as to, even at this early juncture, the uptake of ED positions in this province towards our project?
Yeah, sure. So we have about 5 emergency physicians in interior health. Actually, 1 at each site so far that have reached out to me and are interested in participating in a team. And so one of the key things, I think, in terms of helping recruit, or helping decide who is part of your team, one first thing you can always do is connect with a physician QI department if you have one within your local health authority, because that's a really great place to kind of help them recruit. And there's also me as well, myself and Colin. And we also have, I believe we also have we have 1 team signed up in Northern Health, so Prince George as well. And that is led by an emergency physician, and they are working with, partnering with the radiology team there. And they're also looking into partnering with their Indigenous partners up there as well. And we also threw the suggestion of physiotherapy as well. So you can see the makeup of the team, basically who you know you mostly interact with around having conversations around imaging and appropriateness as well.
Thank you, Sarah. I'll just say one more thing before I turn over to Julian, and that is that at the St. Paul's Project, often patients want something, okay? They want some sort of intervention. It may not be an MR or a CT, but they'd like something to deal with their pain other than medication and advice. So what we try to do is facilitate a fast referral to physio. We thought that would be a beneficial thing for the patient and maybe meet their expectations. Unfortunately, because of how busy physio was, we were not able to do that. That was a while ago. I don't know how things have changed, but I think that's a really important consideration for other projects in BC to, okay, if you're not going to image, what can you offer that is, we know, impactful in managing the patient's symptoms? and how can we offer it more quickly. Anyway, thanks, Sarah. Thanks for that. We're really excited to already have 5 different emergency departments involved in essential imaging. Julian, over to you.
Great. Thank you very much, Bruce. So thank you, Sarah, for bringing this to our attention. And thank you, Colin, for summarizing the campaign that's going to go forward. And Bruce, thank you for your presentation as well on the evidence stuff. I want to open it up to questions. Certainly, please put your questions into the chat box, and I'll read them out. I know that you can't see them very well, so I'll just, or easily. So I'll read out a couple of comments and questions. I'm going to ask you my question, or a couple of questions, if you don't mind, for my own selfish reason. I start about the actual choice of topics, and I'm interested. And it's interesting that 2015, 2016, CAPE, Canadian Association of Emergency Physicians, came up with their list of 10 things, and so we're familiar with this stuff. We're, this, as you said very clearly. We know that you shouldn't order X-rays for low back pain and all the other ones. And so, what is your take on the lay of the land now? Have we actually moved the dot just because we're aware of it? And why is it that we don't move that dot?
It's a great money question, actually. Julian. So I'm aware a little bit of literature in emergency medicine in appropriateness, and there was one article by Lin et al. In the Academic Emergency Medicine Journal 2017, and they looked at this question, the uptake of choosing wisely recommendations by ER physicians in Canada, and what they found was that patient and family pressures were a big factor in why patients, for example, were given antibiotics for sinusitis, and in the case of PE, it was the fear of missing a very important and life-threatening diagnosis. And believe me, even before COVID, that was true. And with COVID-19, it's potentially even more true with its thrombotic tendencies. So I think that I think what we've shown, and some of this data is not brand new, Julian, as you noted, it's around the time the 10 rules were written. I think there's a lot of complexity in your environment. It makes it hard to initiate all rules. But we were able to show, at the time we did the study, that with point of care decision support, we can make a difference. And I think that's really important. And this is in the literature. I mean, we know that point of care works better than posters and lectures. And so I think we'd love to do that in a more fulsome way in this province. We are very challenged by informatics issues with different systems that are not easy to crack. So that, I think, is the way to move forward. And I think it is that's one of the reasons it hasn't been so successful across the board.
Great. Thank you very much. I'm just curious, last little question, then I'm going to open it up and I get to make sure the other people have their questions. Choice of topics. I'm kind of puzzled by the fact that the MRI for knee and hip osteoarthritis. I mean, I honestly don't know of any time that I've ever ordered an MRI. I can't get one anyway, but for something like osteoarthritis. And I'm just wondering why that ended up on the emerge list as things you wanted to change. Just curious.
Okay, so that one, I didn't even talk about that one because it didn't really pertain to you, as you say, Julian. You guys don't order many MRs of joints, in particular knee and hip, we're talking here, from the ED. But the idea of the project is not quite that. The idea of the project is we see a lot of referrals for MRI of the knee and hip in patients with advanced osteoarthritis. MR of those joints in those scenarios is a complete waste of time. No one is going to operate on a meniscal tear in someone with end-stage OA. And this is evidence-based. New England Journal repeated a number of times. So that's a complete waste of time. So our project was to get X-rays of everybody, weight-bearing X-rays, before those joint MRIs were ordered. And if they had, on a validated scale, moderate to severe OA, the MR was refused unless there were red flags. And there were very few red flags, basically sarcoma and infection. So that was that project. And, it's the same kind of numbers. We were able to reduce the number of inappropriate MRIs, but it went from about 22% to about 15%. So we made an impact there, but it was a different type of project. It's the opposite. We're not ordering MRs for osteoarthritis. We're trying to avoid it.
Okay, thanks, Bruce. I'm going to pop over to the chat box here. Cindy Ann Lucky, shout out to Cindy Ann. the challenges do appear to lie with patient expectations, as you say, personal or based on care providers sending to the emergency departments as well. Variation among emergency physicians due to comfort levels. Can you comment on that? There's risk takers, there's risk minimizers in all physicians, healthcare providers.
100%. So I agree totally, Cynthia. Nice to have you on the call here. We work together at UBC ER, Urgent Care Center. So basically, I agree, and I sort of gave that example of this recent article in the literature about what prevented success. And when it came to sinusitis, which is one of the things on your list, it was patient and family expectations. So I think we have a lot of work to do with this shared decision-making. Remember, it is a shared decision-making. It isn't just the patient, of course, making the decision. So we need better materials. We need to make them plug and play. We need to be able to have a program with follow-up, that will help patients make contribute to making the right choice. But what you say there is so true. We did a little project at St. Paul's where we had a radiologist speak to 10 patients who had low back pain and explain why imaging wasn't necessary in the vast majority of cases. And I tell you, at the end of the session, the patients mostly didn't buy it. Like this was a 1-hour presentation. And it's very difficult, right? I mean, I'm not trying to minimize this. It's extremely difficult to do. So we need to do a better job of that. And I think that the Consumer Reports material that Choosing Wisely has together, and importantly, what we've put together on the Essential Imaging website will hopefully be helpful. So please do make use of that material that's available now from our Essential Imaging website.
Yeah, and just to add to that.
Sorry, I could add to that as well, if you want.
Right.
Yeah, I can add to that. So yeah, to Bruce's point, the resources that we have, and it kind of answers Heather's question there as well. We partnered with Choosing Wisely. So basically, we did take their resources and adapted it to the BC context and also to the BC guidelines as well, and try to make it specific. And our patient partner was incredibly active in that. And so what we're kind of hoping within the action series, so this learning series, is that if a team do want to test these resources out to see, do they actually create change, and it's a sustainable change and it makes a difference, that could be a change idea in which we then come in and support and find out whether it is making a difference or not.
And Sarah, I just wanted to add to that. I think the BC Emergency Medicine Network is really also has a very important role to play in all of this. And it's quite clear that patients' expectations and the ability to provide patients with information that they can take home and further review and reflect upon is really important. And so I've already looked at the Essential Imaging packet, the 5 points, and we have a lot of that stuff there, but I think we can make sure it's well synced with what you have, so that we're able to provide to the patients a whole section about why they should or should not get imaging at some point, what they need to watch for. So I think this is really important. I think it really stresses the importance of shared decision making. And that this is really an excellent opportunity to provide that opportunity for us as clinicians to help patients and help ourselves in terms of our communications with them. You want to say anything else at this time, Bruce or Colin?
No, I mean, I just add that, again, hi, Jim, I see you on the line now, and your work, that of Julian and your colleagues, to put together the network, puts emergency medicine in a much better place than other specialties who don't have such a network to share resources like this.
Yeah, thanks. Colin?
No, thank you. And thank you for this opportunity, Julian.
Okay, thanks. And I just wanted to, Eric Grafstein made a comment. Cindy Ann's comment is an important one. One of the ways to support the decision to not test at that time, is to create a robust virtual follow-up model for emergency departments that will allow patients to feel supported and understand that someone will check up on them. I recently saw a patient from the UK with low back pain. I spoke to her regularly after her discharge to make sure she was okay with not being imaged. Regionally, we are looking at virtual follow-up models to support this sort of process. Stay tuned. Eric, did you want to speak further to that?
Yeah, thanks, Julian. So, I think, virtual health will see its way, make its way to emergency medicine for a variety of reasons. And this is actually a good one. I think telling someone, I don't think you need a test, but I'm going to follow up, or someone's going to follow up with you is a way that they can, live with the decision not to have imaging now, and a significant percentage of them will feel better, especially with low back pain. And the trying to work with the doctors of BC to understand whether or not APP sites can set up a clinic-type structure, a virtual clinic-type structure, so that they can bill fee-for-service for these. We would establish criteria for doing that. And so far, I've inquired twice, and I haven't heard anything from the doctors of BC lawyer. And so I just sent out another email, but I don't see a reason why we shouldn't be allowed to do that. And I think it's the whole, it wouldn't just be for this, it would be for patients who are sick who want to follow up. But I think there's lots of opportunity to really enhance the choosing wisely paradigm in a virtual follow-up model.
Yeah, that's a great point, Eric. I think that, there are a small percentage of patients who don't get their exam at first presentation who end up needing an exam later, right? And again, if you look at physician confidence in some of these guidelines, I think it would be enhanced by knowing that there's follow-up, that the patient does get worse. If they develop a foot drop in the case of low back pain, or develop a fever, that will be transmitted and the patient will be, cared for in an optimal fashion. So I think that would be great.
Excellent. Thank you. Ryan Hoskins. Shout out to Ryan. Great presentation. One trend I believe I have seen is that more radiology reports say recommend follow-up exam for some kind of finding. Perhaps this is because of new generations of technology. Perhaps this is because new generations of radiologists taught to look in more depth. Perhaps I am incorrect. Is this something that is being studied by Choosing Wisely?
Well, that's a very good point, Ryan. And I think that there is one a vignette I'll give you briefly. I think we have time. So we were originally going to study at St. Paul's Hospital the issue of follow-up of adnexal cysts. This is not so much an ER topics maybe, but when you do a pelvic ultrasound on a woman and you see an adnexal cyst, the idea is if they're postmenopausal, as long as it's less than 3 centimeters, and premenopausal less than 5 centimeters, as long as it's a simple cyst, you don't need to follow them up. But radiologists are we were told that radiologists are putting in their reports to suggest follow-up ultrasound when it wasn't indicated. So for sure, radiologists can contribute to the problem of inappropriate imaging. I don't deny that at all. And that's work we have to do ourselves. When we looked at this problem, though, we found out that it actually wasn't the case, that it was, I guess, maybe more of an anecdotal scenario for a physician or two. In fact, those recommendations were not being made. But you'll notice, I don't know if you noticed on the American College of Radiology recommendations for Choosing Wisely, that was one of them. Don't do pelvic ultrasounds for follow-up of adnexal cysts. So we will continue to look at that. Yes, technology has played a role. Yes, we're seeing smaller lung nodules. It drives us crazy. Okay, it really does. But we follow the Fleischner guidelines, which are the international guidelines for follow-up. So we are watching the literature. It is changing. It's making the follow-ups less frequent. But all we can do is go with the literature. So that's what we do. I can't comment on the other suggestions for follow-up. I don't have any data about that. Our physicians practicing more carefully in this day and age than before, probably in every way, including in radiology. But we need to make sure that we're, for the most part, privy to these important guidelines to reduce this low-value imaging.
Thank you very much. See any other questions there?
There's one about ethanol. What about ethanol intoxicated patients with decreased level of consciousness frequently get head CT with extremely low yield? Yeah. I think that's a nuancing thing. And I think when you can't get a history, what are you going to do, right? You're stuck in a difficult place. I don't see anyone, I can't imagine people criticizing ordering a head CT in a situation like that where you're unable to get a history.
Okay. Yeah. Thanks. Yeah, I think it's a case-by-case scenario. It depends on who the person is, and I know Rob knows this already. But anyway, so yeah, it's a good point. There are always going to be outliers on these things that we have to take clinical judgment into consideration. Jim has a question on research incidental findings.
Thanks, Julian. A great presentation, everybody, and such an important topic. And I really like how balanced it was, so thanks a lot for doing that. I have a question, and I've seen it through my career and actually have some personal experience, Bruce. And I'm wondering if the literature, and it seems that when you look at the negative outcomes, the patients that had something significant that was missed, a significant pathology that was missed when you apply the guidelines. It's extremely rare, but still possible. But there's another side of that, and that's the incidental findings. So is there when these things are looked at, like it could be that a test was done inappropriately, imaging was done inappropriately, but something away from the actual primary area of interest was found that, say, for instance, diagnoses an early cancer that was asymptomatic that could be treated, and maybe if it wasn't found, couldn't be treated. Does that ever work its way in the literature? I know it's relatively rare, and I know these incidental findings are kind of difficult to know what to do with, but there's clearly some cases where it becomes an important finding.
Sure. There's a whole body of work on incidental omas, as we call them, Jim. And an example is an adrenal adenoma on, say, a CT abdominal from the eMERGE. And so, it's important for the radiologist to follow the guidelines because we can make a diagnosis of a lipid-rich adenoma. And when I report such an incidental finding, I say no further follow-up is required unless clinical conditions, change. Because sometimes we'll get a request follow-up adrenal adenoma, right? So, it's important that the radiologists communicate carefully what the next steps are, and if there aren't, then to say so, okay? In terms of finding, important stuff, we do find important stuff. Incidental renal cell carcinoma is probably the best example. The problem is, what do you do with that, right? We know that people die. It's the most common neoplastic finding at post-mortem, right? People die of it, or with it rather than of it a lot of the times. So, it's very difficult to determine which are aggressive and which are not based on imaging. You can't do it, right, unless they're invading other structures. So it's a very difficult topic, and we do find them, and they do get sent to urology, and we don't biopsy them. That urologists don't do that. They want to wedge them out if the patient agrees, and then that discussion is ensuing. But they aren't common, but that's a good example of one. On the other side, there's a well-known case of a radiologist who had an adrenal adenoma that was inappropriately sent to biopsy. He got a pneumothorax from the biopsy and had complications from that and was in the ICU for a short time. All for biopsying something that was completely meaningless, and a study that may not even have been indicated. I don't know the answer to that last question. So so there's both sides of the coin. You can find stuff that's important. You can find stuff that isn't. And then if the wrong pathway is taken downstream, you end up in trouble.
Great. Good perspective. Thank you.
Great, thanks. We have 2 minutes to go, so I want to just wrap it up and give people time to get to the next appointment or whatever, the meeting. Bruce, thank you very much. Colin, thank you very much for your presentations. Excellent topic, important topic, and something we need to keep working at. Sarah, did you want to provide one last link to the resources that people should sign up? And the deadline is February 1st.
Yep. I can definitely do that for you.
Awesome.
Thank you. Sorry, I totally interrupted you there. That was rude.
Oh, don't worry. I'm cool.
Well, thank you all for the opportunity here. We really appreciate Julian and Jim for the invitation, and look forward to seeing you on a regular basis, and hopefully as part of this project, this initiative. We think we can, really, I think, move the dial here in BC, and we've got a great team down at the council. So look forward to working with you.
Yeah, excellent. Thank you. Okay, so everybody can see in the chat box the link and also Sarah's email, but you can also go to the BC Patient Safety Quality Council website and Essential Imaging. So thank you very much, everybody, for your great talks, and thank you, everybody else, for your participation. Have a great day.
Bye.
Ciao.
Cheers.
Bye.
Bye.
You are the only participant in the conference.